so I am only one to conduct. And if you agree to my decisions, so I continue. Otherwise, I have to arrange for someone else, as you all say. Start the session? Okay. The first presenter will be on. The first presenter will be Atul Mishra on choroidal melanoma, a rarity chief and presenting author. Who is presenting? Yeah.
Yes, sir.
Timing कितना दिया आपको?
Sir, 5 minutes.
5 minutes. Okay. 3 minutes. 3 minutes.
3 minutes.
Yeah.
All right, sir. Good afternoon, everyone. Today I'm presenting an e-poster over the topic choroidal melanoma rarity. I'm JR2 presently situated in MMU Solan, Himachal Pradesh. Next slide.
Timer of 5 minutes. 3 minutes.
5.
Okay.
Sir, this pink e-poster
Okay.
is
3 minutes.
3 minutes.
3 minutes कर दी. 3 minutes. उसके बाद वो ठीक हो जाए.
Materials and methods. 86 years old male came with loss of vision in right eye and pain, right side headache since past 3 months. Loss of vision, gradual, progressive, painful, no associated prostration, no associated systemic diseases. Best corrected visual acuity, PL negative in the affected eye, IOP 42, pupil slightly dilated, non-reactive, lids and adnexa normal, NTS segment, image and video available in the next slides. Posterior segment, no view, B scan, image and video presented in the next slides. Rest, the left eye within normal limits. Anterior segment, right eye and anterior segment, AC flat in central, peripheral both. Pupil slightly dilated and non-reacting. Cataractus crystalline lens present. B scan, collar button or mushroom shaped lesion. Collar button, mushroom shaped lesion is most classic presentation. Solid consistency, slow to medium internal reflectivity in a low to medium internal reflectivity in a decrescendo fashion. Serous retinal detachment extending from margins of tumor. Apical height 12 millimeter, large basal diameter 18 millimeter. That is large in size. Blood investigations, hemoglobin 14.6 gram percent. RBC 4.47 million per cubic millimeter, TLC 4.80 into 1000 per cubic millimeter, platelets 109 into 1000 per cubic millimeter, CSR 20 millimeter at 1 hour, liver functions within normal limits, bilirubin total 0.66 milligram per deciliter, renal functions 58 and 0.95 within normal limits, D-dimer 1374 nanograms per milliliter, radiological investigations, ultrasound, abdomen, no liver metastasis, chest X-ray showed no lesions over lung field, so suggestive of no lungs metastasis, 2D echo, pulmonary hypertension. MRI findings of right eye, well-defined altered signal intensity with broad base towards wall, involving lateral half of posterior chamber of right globe in subretinal location, right side retinal detachment with subretinal and vitreous hemorrhage. Discussion, presentation, asymptomatic tumor discovered on routine ophthalmic examination, 25% of cases, photopsia, floaters and visual field defects, decreased vision, tumor encroachment on the fovea, exudative retinal detachment involving macula, tumor contact with lens, severe pain, inflammation, massive extraocular extension or neovascular glaucoma. Clinical features, visual acuity loss, flashes and floaters, visual field loss, B scan, cardinal features, solid consistency, collar button shape, low to medium internal reflectivity in a decrescendo fashion, regular internal structure, internal blood flow. Fundus fluorescence angiography, large melanoma, mixed early hyperfluorescence, simultaneous fluorescence due to choroidal and retinal circulation, double circulation pattern, optical coherence tomography, melanoma, irregular indistinct margins, subretinal fluid, oblong configuration, elevated edges. Management, criteria for size, apical height, largest basal diameter 1 to 2.5 millimeter or 5 millimeter, largest basal diameter, apical height 1 to 2.5 millimeter, largest basal diameter 5 millimeter. Treatment option, laser photocoagulation, transpupillary thermal therapy. Apical height 2.5 to 10 millimeter, large basal diameter 5 to 16 millimeter. Plaque radiotherapy, proton beam therapy, stereostatic radiosurgery. Greater than 10 millimeter, greater than 16 millimeter. Customized plaque RT radiotherapy, enucleation. Thank you.
Time over. Thank you. Nicely presented. But I will request that the investigations which are normal, you can just say as normal instead of, because you are already presenting, so that you can move the contents properly. Okay, thank you.
Thank you, sir.
The second presenter will be a rare case report of Sturge-Weber syndrome by Ankita Mishra. He is here? No, she is not there. Okay. The third will be facultative glaucoma in a case of traumatic subluxation of lens. Rakesh Kumar, correct.
Hello. Hello. Hello, sir. So my case is phacotopic glaucoma in a case of traumatic subluxation of lens. So glaucoma can be primary or secondary, and secondary glaucoma, the glaucoma that has a typical and particular cause, we can diagnose that. And phacotopic glaucoma is glaucoma when there is a lens-induced glaucoma. The subluxation or the displacement of the lens cause the interocular pressure rise, and with changes in the optic nerve that can lead to glaucoma. So my case is a 50-year-old female patient to the OPD with complaining of intermittent pain and intermittent watering from the right eye. She has a history of injury in her right eye while fetching the mango, and the mango fall in her right eye. After that, she is complaining of intermittent pain, redness and watering for the same eye. So when we examine the patient, the visual acuity was hand movement in the right eye, and left eye it was 660. With correction it came in 690 in the left eye, but hand movement in the right eye. With that, there is a decrease in the near vision in the right eye with N18 vision with plus 2.50 diopter. So after examining the eye, CLM examination, we can see there is a subluxation of the lens in the right eye from the 11 o'clock to journal deviation from the 11 o'clock to 3 o'clock, 4 o'clock hour, and there is a PI present in the right eye at 10 o'clock, which is done outside elsewhere. So we go for the gonioscopy, and gonioscopy shows the Bonner is getting in the right eye was in grade 1 and grade 2, grade 1 in the left eye also, but the IOP was 14 in the right eye, and the USG B scan shows anterior dislocation of the lens in the right eye. So we go for fundus imaging and OCT RNFL, and fundus imaging show the right eye showing the neuroretinal thinning in the superior and inferior quadrant, and there is the present of optic disc pallor in the right eye, and OCT also showing that there is a superior neuroretinal thinning in the right eye. So we diagnose, after this we diagnose the case of phacotopic glaucoma in a case of traumatic subluxation of lens. After doing biometry, the axial length was within normal limit, the keratometry in the both the meridian with the normal limit. We go for lens extraction with PCL implantation with CTR ring placement. After we place the CTR ring, after doing the hydroresection and doing a big rexis, and the IOL is placed, and we place a air bubble to maintain the anterior chamber. We can see the photo post of day 1 photo on the right side and the post of day 2 photo in the left side. We can see mild striate keratopathy in the cornea, but the lens is in the position. So after 2 weeks of the follow-up, the patient is gain a vision of 624, and from this we can conclude that ectopial lentis can be a systemic cause, can be trauma. But if in case of trauma, we have to see the general dehiscence in case of clock hours, and after that we have to place the CTI ring properly according to the general dehiscence present in the clock hour. But in the systemic case, we have to be more careful because there is the association of Marfan disease or homocystinuria. So this is my case. Thank you, sir.
Thank you. The next presenter will be management of ocular hypertension and corneal opacity in the case of mucopolysaccharidosis type 4, Rathina Murare.
Good afternoon, everyone. I'm going to talk about management of ocular hypertension and corneal opacity in a case of MPS type 6. Starting with the case report, a 9-month-old baby presented to us on May 2016 with complaints of both eye discharge and watering with increased sensitivity to light. She had a positive family history of hypermetropia and consanguinity. On examination, she had features suggestive of both a congenital nasolacrimal duct obstruction with diffuse corneal haze suggestive of chorymegalocornea. It was not resolving with conservative medical management, so examination under anesthesia was planned along with right eye probing and both eye syringing. Examination under anesthesia revealed normal horizontal corneal diameter of 13 mm and normal features of optic disc, which rules out congenital glaucoma. She was followed up regularly. The complaints got reduced. On July 2017, she was referred to pediatrician with the suspicion of mucopolysaccharidosis, as she had these characteristic skeletal features. And on complete systemic evaluation with molecular genetics, she was diagnosed to have MPS type 6 syndrome. After 3-year lapse in follow-up, she presented to us back on September 2020 and is on regular follow-up till now. On each follow-up visit, all the necessary investigations were done. This is the IOP chart of the patient. IOP is usually in the 40s range. During her last follow-up, it was around 55. During her last follow-up, she was underweight with a BMI of 15.84, high hypermetropic correction, telecanthus, and corneal haze over limbus to limbus. Both eye B scan revealed no evidence of disc cupping. Moving on to treatment, as MPS rarely progresses to developmental glaucoma and there's a probability of IOP overestimation due to thick corneas, she was started on both eye brinzolamide eye drops arbitrarily. These are the parameters of her last follow-up visit. Low vision rehabilitation with video pocket magnifier and dome magnifier was given. Tinted glasses were given to relieve her of photophobia. There was a drop in visual acuity from the previous visit, so both the penetrating catoplasty possibility was explored, but it was deferred due to chance of recurrence or rejection, and also patient had a clear ambulatory vision with fixation to light with no signs of nystagmus. So she was advised to continue both the brinzolamide eye drops and to review periodically. Moving on to review of literature, MPS type 6 or Maratolami syndrome is of autosomal recessive inheritance. It is due to mutation in the ARSB gene, which is located on the long arm of chromosome 5. Which results in an accumulation of dermatan sulfate and chondroitin sulfate. Incidence and prevalence depends on the ethnic population. High rates of endogamy and parental consanguinity will determine an increase in prevalence. In India, it is yet to be estimated. These are the clinical features of MPS type 6 patients. They will be of short stature with the dysostosic multiplex will be present. And these are the ocular manifestations: corneal clouding, ptosis, acute and chronic angle closure open angle glaucoma with optic nerve atrophy and papilla edema. Progressive corneal opacification is one of the major contributors to low visual acuity. There are two distinct phenotypes associated with the disease: rapidly progressing, which onset before the age of 2, and attenuated forms, which are slow clinical course. Akil et al. Came up with the guidelines. To conclude, MPS type 6 needs timely follow-up, regular follow-up, and interdisciplinary treatment with timely surgical intervention to improve the therapeutic outcome. Thank you, sir.
Thank you. The next presenter will be a rare case of ocular ischemic syndrome, Ahmad Ali. नहीं है Ahmad Ali. The next will be a rare case of multiple cranial nerve palsies in herpes zoster ophthalmicus, Reshmi Shri Kumari. Then next will be a rare case of optic neuritis and a case of neuromyelitis optica, Suhasini Chaudhary.
Suhasini Chaudhary. Good afternoon, everyone. My case is a rare case of optic neuritis in a case of neuromyelitis optica. NMO is an inflammatory antibody-mediated immunological disease of the central nervous system that causes demyelination of the optic nerve and spinal cord. It has a low prevalence at 0.3 to 4.4 per 1 lakh population. Median age is 40 to 50 years, much more common in females, suggesting ratio of 9:1. It may have a monophasic or relapsing course. MOG antibody disease has been recognized as a distinct demyelinating disorder, around 10% among the non-infectious optic neuritis. A 60-year-old man came to Rio OPD on 20 January 2024 with complaints of diminution of vision, both eyes, for around 6 months. It decreased significantly within 1 week in the right eye. It was acute in onset, gradually progressive, not associated with pain, watering, redness, no fever, flu prior to vision loss, no history of diabetes, hypertension, dyslipidemia. Anterior segment and visual examination, visual acuity PL positive right eye, left eye 618, pupil RAPD grade 1 in the right eye, and left eye is normal. The IOP is normal, rest within normal limit. The blood investigations were normal, and on ocular findings, there is hyperemic disc pallor, vessels mild engorged, CDR not appreciated, color vision was defective. On imaging, MRI brain fazeca grade 1 white matter lesions were found, and on bilateral orbital screening, resolving bilateral optic neuritis present, MRI spine disc protrusion and hypertrophic phlegm at L4, L5 and degenerative changes. Serology is anti-MOG antibody strongly positive, and CSF is negative for oligoclonal bands. OCT RNFL thickness decreased, bilateral eye, OCT macula central subfield thickness decreased, VP P waves decreased, visual fields, sedal scotoma with contraction of peripheral visual field. Treatment, intravenous methylprednisolone 1 gram for 3 days was started. Oral prednisolone 1 gram per kg body weight for next 11 days, then tapered over next 3 days. The patient has recovered and vision is recorded 6/9 right eye, 6/9 left eye with 8. He is still on follow-up. Antibody appears to mediate directly complement system, leading to central nervous system inflammation. Optic neuritis has been reported to be most common first clinical manifestation in MOG AD. It is typically severe but final good visual outcome after treatment, consistent with her case. The MOG antibody serology during the acute optic neuritis episodes was found to be positive in our patient, which is considered as a diagnostic marker during the acute episodes. Thank you.
Nicely presented. Next will be Devangi Joshi on the silent threat, neovascular glaucoma, a splenic feature of the chronic myeloid leukemia. Ocular ischemic syndrome. Sorry. Ocular ischemic syndrome.
Good afternoon, I'm Devangi Joshi and I'm here to present a case study on ocular ischemic syndrome. It's more than just meets the eye. It is rare, it is a potentially blinding condition with an estimated occurrence of 7.5 cases per million people per year. It's quite rare. So it occurs due to hyperperfusion of the eye because of internal carotid or ophthalmic artery occlusion or stenosis. It manifests acutely as sudden diminution of vision or transient ischemic attacks, and chronically as gradual vision loss or orbital pain. It can also have varied manifestations like retinal ischemia, neovascular glaucoma, and anterior segment ischemia. Apart from ocular symptoms, it is at risk for cardiovascular attacks and cerebrovascular attacks. The clinical signs are important in OIS. The anterior segment signs and the posterior segment signs are written here. Further evaluation was FFA, ERG, VEP, etc. Carotid Doppler imaging helps clinch the diagnosis. Management should be done with a multidisciplinary approach with coordination with neurologists, cardiologists, and vascular surgeons to treat the causative factors. In our case study, the patient came with a marked vision loss, angle closure and NVG at an IOP of 8, and there was no clear cause for the NVG on an ocular examination, so our field of scope had to be broadened to diagnose the patient. There's a case report of a 65-year-old male who presented with painless, gradually progressive diminution of vision in the right eye. He had a known case of diabetes mellitus, hypertension, CKD, and CAD, and with a history of smoking. In the vision, the right eye was finger counting at 2 meters with no improvement on pinhole. In the anterior segment, as you can see in the photo, there was conjunctival injection, centroclear cornea, 270 degrees of fluorid NVIs with ectropia on UVA, quiet anterior chamber, mid-dilated pupil, posterior synechia, and asymmetric cataract. The left eye anterior segment was within normal limits. The gonioscopy in the right eye was all the angles were closed, as is depicted in here, superior angle. The fundus photo through a hazy media is depicted here with the cup was CDR of 0.8:1 with inferior notch and discollaterals. There was arterial attenuation with venous dilatation, and a few retinal hemorrhages were present in the mid-periphery. In the left eye, there were a few corneal spots, but the disc was within normal limits. An area of blood tests were done which revealed hypercholesterolemia but nothing else, which helped us to rule out CRVO. In carotid Doppler imaging, we found complete occlusion of the right common carotid and the external. So this helped confirm our suspicion of ocular ischemic syndrome as the cause of neovascular glaucoma in this patient. The patient was referred to cardiology where you started on anticoagulants. From our side, we gave him 1 dose of intravitreal rhinosumab, after which complete regression of NVI was seen. Further, the patient was planned for, the patient underwent phaco with iris hooks and PCI was implanted. The vision improved till 660. The patient also, since the patient showed signs of ischemia with closed angles on gonioscopy and NVI and in CDR of 0.8, we thought of it was neovascular glaucoma. But since the IOP was so low, we needed further investigations. Possible explanations for this was ciliary body ischemia and reduced aqueous humor production because of hyperperfusion. So on Doppler, we found it was OIS. Prompt diagnosis and timely intervention can restore the sight and even may save the patient's life. Thank you.
Nicely presented. Next presenter will be the silent threat. Sorry, 1 minute. Devangi ho gaya. The silent threat, neovascular glaucoma is presenting feature of chronic myeloid leukemia. Nishkash Bansal.
Yes. Good afternoon, sir. I'll be presenting the case of neovascular glaucoma, which came out to be the presenting feature in a CML patient. Starting with the first slide, ocular involvement is already noted in about half of the patients of the leukemia at the time of the diagnosis, but they're almost every time asymptomatic or usually present late. But this case report highlights a rare complication of leukemia, which is retinal vein occlusion leading to neovascularization, which turned out to be the presenting feature. A nil comorbid 45-year-old male diagnosed with CRVO outside with NVG with uncontrolled pressures came for a second opinion, and on presentation had PL positive and counting fingers close to face, visual acuity with IOP of 42 and 38 respectively in the right and left eye, and on examination revealed bilateral neovascularization of the iris with grade 1 hyphema and 360-degree peripheral anti-synechy. On fundus evaluation, 0.8 to 0.9 cupping was noted in both eye with arterial as well as venal attenuation, vessels attenuation, along with that mid-peripheral hemorrhages. Systemic workup was done for the patient, which revealed high total leukocyte count, and the peripheral blood smear also revealed marked leukocytosis with neutrophil in prominent population of myeloid precursors suggestive of chronic myeloid leukemia. And for the confirmation, BCL-ABR gene was done. Finally, the patient was diagnosed to be a case of both eye neovascularization glaucoma secondary to CML. And patient was started on imatinib 400 mg once a day, along with that topical steroids with cycloplegic and maximum AGMs. Patient eventually underwent with the left eye intravitreal VEGF injection followed by a PRP augmentation, and finally left eye phaco with IOL and orolab implantation was done to control the high pressures. As you can see, ADI implant was implanted and phaco with IOL was done with placement of tube 2 mm into the AC and secured with scleral graft. At the follow-up, the post-surgery topical steroids and cycloplegics were continued with the same anti-glaucoma therapy. At 4 weeks, IOP was noted to be 8 mm with shallow AC and few membrane formations. Hence, all AGMs were discontinued and eventually IOP was stabilized. Visual acuity at the last visit was light perception in the right eye and hand movements in the operated left eye. And patient was continued on imatinib with eventually TLCs coming into the normal range. Coming to the discussion for the case, the ocular symptoms are observed in approximately half of the leukemic patients as mentioned before, but the presentation at this stage is really barely uncommon, and if it's present, it has been linked to certain conditions such as CRVO, leukemic retinopathy and prolific retinopathy. The proposed mechanisms which have been discussed for the same, the first one, that is the leukemic infiltration, which can obstruct the trabecular meshwork, resulting in chronically elevated IOPs. The second one is the linkage between the hyperviscosity syndrome associated with CML, leading to increase in VEGF factors and finally leading to neovascularization. And the third one, which is a rare possibility, is of imatinib inducing a leukocytoclastic vasculitis. So coming to the conclusion, it's apparent that the patients of CML might present with ocular manifestations, but first, the presenting feature to be an ocular feature is a bit rare, and also the role of imatinib cannot be ruled out, because imatinib can also lead to leukoclastic reaction. Thank you.
Thank you. The next presenter will be bilateral persistent fetal vasculature, the unusual suspect, by Sujay Sagar. Sujit? Sujay ना? Sujay Sagar. Yeah. ये आपका seconds में नहीं आ सकता क्या? Timer seconds में नहीं आ सकता क्या?
Okay, good afternoon, everyone. I'll be presenting a case on bilateral persistent fetal vasculature, the unusual suspect. So coming to introduction, PFV was earlier known as PHPV, which is a congenital ocular anomaly in which the embryonic hyaloid vasculature network fails to normally regress partially or completely. Genes and factors that have been proposed in this mechanism are loss of WNT7P signals in hyelocytes, factors such as angiotensin 2 or P53 that may affect endothelial cell apoptosis, deregulated vascular VEGF, and the absence of ARF tumor suppressor. It is usually unilateral and seen in term infants. Very rarely, bilateral presentation has been demonstrated by Pollard and Haddad et al. Systemic conditions such as trisomy 13, 15, 18, Norris disease, Peters anomaly, Warburg syndrome can be associated with bilateral PFV. Clinical presentations include leukocoria, nystagmus, microphthalmia, grayish membrane on the pupillary margin, retinal detachment, and vitreous hemorrhage. Very rarely associated with retinoblastoma, Peters anomaly, persistent pupillary membrane, retrolental fibroplasia. It is predominantly a unilateral condition. Bilateral cases account for less than 10% of cases in the literature. Purpose of this study is to present a rare case on bilateral PFV. And coming to the case report, an 8-year-old child came with chief complaints of gradual painless diminution of vision in both eyes. He had involuntary movement and inward deviation in both eyes. History of spexing since 2 years. Birth history was full-term normal delivery with history of consanguineous marriage. Birth weight was 2.5 kg. No history of NICU stay and normal developmental milestones. The vision unaided was finger counting 3 meters equal to, and with glasses was 330 parts. So on ocular examination, on Hirschberg's test, right eye esotropia was seen 20 degree. On cover-uncover test, he had alternative esotropia with manifest pendular nystagmus. Microcornea was seen as the vertical diameter is less than 10 mm. And rest, on torchlight examination, AC, iris, pupil, and lens was normal, but on slit lamp examination, dilated, we could see peripheral cortical spokes in both the eyes. So coming to fundus examination, a thick band was extending temporarily to the optic disc. There was a macular fold with underlying RP changes in both the eyes on 360-degree fundus view. And B scan was done, which showed a color, axial length measuring 18.99 millimeter in right eye and left eye 19.47, suggesting microphthalmia. Also, the stalk was seen, leaving the vitreous and the lens clear, but the macula was seen on the fold. So how is our case different from others? This patient had a very late onset of presentation. The stalk extended temporarily to the optic nerve head. Also peripheral cataract was seen, and the patient had very poor visual acuity with alternate esotropia and nystagmus. So basically in discussion, very few cases of this are seen, and we have to also rule out early diagnosis and appropriate treatment, which would prevent progression of visual loss later in life. So, yeah.
Thank you. So next will be association between POAG and metabolic syndrome among the patients attending a tertiary care center. Aswathi Venugopal.
Good afternoon, sir and all. My topic is association between POAG and metabolic syndrome among the patients attending the tertiary care center. As everyone knows, glaucoma is a leading cause of irreversible visual loss and disability in the world, and it's a multifactorial chronic optic neuropathy characterized by a progressive loss of retinal ganglion cells with subsequent field effect. Now, metabolic syndrome is a cluster of metabolic abnormalities, which include central obesity, hypertension, hypertriglyceridemia, and low levels of HDL cholesterol. It's found that 1/3 of India have metabolic syndrome, and this is the definition of metabolic syndrome by NCEP ATP3 criteria, where it says presence of any 3 or more of these 5 symptoms, where abdominal obesity with a waist circumference more than 102 in men and 88 in women, hypertriglyceridemia, low HDL cholesterol less than 40 in men, less than 50 in women, high blood pressure, systolic more than 130 and diastolic more than 185, high fasting blood glucose level more than 110. Now, there are certain cross-sectional and longitudinal epidemiological studies which have shown association of glaucoma or elevated intraocular pressure with elevated BP or fasting glucose, rather, or sclerotic disease or obesity. So there was a common mechanism linking elevated IOP and to glaucoma to various components of metabolic syndrome. So our aim of the study was to find out association between open-angle glaucoma and metabolic syndrome. And this was a case-controlled study conducted in BMHRC. The ethical committee clearance was taken, and study populations was diagnosed. The criteria was given as by ISGEO, where the inclusion criteria was IOP more than 21 millimeters with NCT, open-angle chamber, optic disc changes, visual field defect by HFA. The exclusion criteria is trauma, history of ocular surgery, or persons with statins. Now, the control group has an inclusion of IOP less than 20, no glaucomatous change, no visual field loss. An exclusion, high myopic, subluxated lens, or trauma history of those. We started patients by taking their vision, IOP measurements, visual field text, and an indirect ophthalmoscopic fundus evaluation, along with an arthrometric measurements of waist circumference was taken, and height by stereometer and weight for a BIMI measurement. Laboratory investigations include blood samples taken for fasting blood glucose, triglyceride, total cholesterol, HDL and LDL from a fresh sample. So risk factors or any associated factors plays a crucial role in early screening and detection of the disease, with which we can't prevent the incidence of the blindness of glaucoma. Metabolic syndrome is found to have a raised IOP, which is significant risk factor for glaucoma. Also interesting finding noted in the study was systolic and diastolic blood pressure was having a statistically significant relationship of IOP among the female participants of the study. And among the 100 patients in group B, which are the cases, metabolic syndrome was present in 84% of the patients, and it was absent in 16% of the patients. And among the 100 patients in the group C, which are the controls, metabolic syndrome was present only in 22% and absent in 78%. Hence, with which we can conclude that metabolic syndrome is associated, and future physicians can consider for a glaucoma screening in those patients. Thank you, sir.
Nice. You heard on one thing only, then you will be in time totally. The features जो आप उसके दिखा रहे हैं ना बात के कि नहीं देखना है जो कंट्रोल ग्रुप को आप लेके चलती पूरा वो स्लाइड में आ रहा था बाकी का तो you will complete time, no problem, nicely presented. Next will be evaluation of serum estrogen levels in patients of POAG and its correlation with nerve fiber layer by Divyanshi Jain.
Good afternoon, everyone. Good afternoon, everyone. I'm Divyanshi Jain, Junior Resident 3, KGMU. The topic of my presentation is evaluation of serum estrogen levels in patients of POAG and its correlation with RNFL. Glaucoma. As we all know, is a multifaceted disease influenced by various factors such as IOP, inflammatory immune mediators, oxidative stress, and genetics. The frequency of glaucoma is more prevalent in men and exhibits a linear correlation with advancing age. This observation implied the role of sex steroid hormones in the pathogenesis of POAG. The primary hormones under scrutiny are estrogen and testosterone. Estrogen, through its effect on ER alpha and ER beta, augments ocular blood flow, reduces intraocular pressure, and provides neuroprotection. Aim of my study was to correlation between serum estrogen with the thickness of RNFL. My hypothesis was serum estrogen is neuroprotective in patients of POAG. It was an observational case control study of duration 1 year conducted in Department of Ophthalmology after the ethical approval. Patients of POAG aged between 40 to 65 years were included, and patients with any ocular or systemic disease which can alter retinal vasculature taking any drugs that could affect sex hormone levels were excluded, along with pregnant and lactating females. My sample size was 90, which was divided in between cases and control equally. All subjects underwent ophthalmic examination and blood sample collection. After the total blood sample collection, ELISA was done to estimate the level of serum estrogen. Statistical analysis was done using SPSS version 21. Results were calculated for each gender separately. As we can see, in women with POAG, significant lower levels of estrogen were found as compared to their age-matched control. However, there was no specific observation was seen in men. Regarding correlation analysis, strong positive correlation was found between patients with POAG and nerve fiber layer thickness in women. However, this observation was not seen in men. Several previous studies also concluded the similar result as my study. So this study reaffirmed the results found by previous studies. Additionally, we established a correlation between the hormonal profiles and the thickness of the nerve fiber layer. Limitation of my study was, my sample size was small and the nature was observational, and we did not account for the changes in serum estrogen levels taken in different phases of menstrual cycle in premenopausal women. Future studies should consider extensive matching of age, genetic background, and other relevant factors in trial group. So, reduced estrogen levels in women with POAG are associated with increased glaucoma severity.
One thing which you have done good, that you have suggested the drawback and what should be done. But one more thing you should add in the next usme, कि after estrogen level goes down, what is the comparison of RNF? Then it becomes equal in male and female. That proves further your documentation.
Okay.
Thank you.
Thank you.
The next present will be isolated inflammatory sixth nerve palsy, the wonder of strides, Mitsa Babeja.
Mitasha. Good afternoon. I'm going to present on isolated inflammatory sixth nerve palsy, the wonders of steroid. A 30-year-old male presented with the complaints of inability to move right eye outwards and diplopia since last 1 month. He also had 2 episodes of headache, throbbing in nature over the frontal and right retroorbital area, radiating to the nasal side of the right eye, not aggravated with light or sound, and not associated with any redness or lacrimation, which subsided on taking analgesics. No history of fever, neck stiffness, photophobia, pulsatile tinnitus, seizures, nausea, and vomiting. Past personal and family history, nothing was significant. On examination, everything was normal except on systemic examination, 6 cranial nerve palsy was seen. On ocular examination, everything was within normal limits, except in the right eye, ocular movements were limited in abduction. On presentation, this was the 9-gaze photo which showed limitation in dextro elevation, dextro depression, and dextro side. And his charting was showing reduced fields in right eye, and left had compensatory increased movement. And diplopia charting showed maximum gaping in the dextro side, and prism bar cover test showed for near and distance, left esotropia 25 prism diopter and right esotropia 10 prism diopter. Fundus examination was within normal limits. On investigations, blood and radiological investigations were within normal limits, except the MRI showed focal parenchymal enhancing thickness involving the right cavernous sinus reaching up to the right orbital apex. Provisional diagnosis was Tolosa-Hunt syndrome. Treatment given was CMC, and omnocortical tablet was given. Initially 40 mg for 7 days, which was tapered every week by 30, 20, and 10 mg. 10 days follow-up, patient had significant improvement in the 9-gaze photo, and the Hess charting also showed improvement. And the diplopia was also reduced. with PBCT for near and near was straight eyes and distance showed alternative esotropia 12 prism diopters. Discussion, differential diagnosis would be Tolosa-Hunt syndrome, sarcoidosis and IgG4 related disease. And IgG4 would require histopathological examination of the brain, which would be invasive, so not suggestive. Sarcoidosis has no clinical symptoms as such in this case. And hence, this is the case of Tolosa-Hunt syndrome, which is usually diagnosis of exclusion, in which patient presents with third, fourth, or sixth cranial nerve palsy with unilateral headache and ophthalmoplegia of the side involved. Conclusion, the mainstay of treatment in either of the provisional diagnosis would be systemic steroids. As discussed earlier, IgG4 and sarcoidosis ruled out, so the patient was provisionally diagnosed as Tolosa-Hunt syndrome and started on systemic steroids, and the patient responded well to the treatment, and his diplopia, headache and pain improved well within few days of treatment. These are my references. Thank you.
Well presented in time. The next will be optic nerve head Duchenne, masquerading as papilledema in young male patients. Anna Abraham. The next will be efficacy of trabeectomy in POE patients. Vijay Singh.
Good afternoon, respected delegate. Efficacy of trabeculotomy in primary open-angle glaucoma. Introduction: glaucoma, the second most common cause of irreversible blindness, is an optic neuropathy. Glaucoma is a heterogeneous group of diseases that commonly involve the loss of retinal ganglion cells and their axon, which result in characteristic alteration of optic nerve and corresponding pattern of vision loss. Material and method: an observational prospective study was carried out in ophthalmology department for 1 year of duration. The prospective study included a total of 45 patients after meeting inclusion-exclusion criteria. The patient with primary open-angle glaucoma are characterized by adult onset more than 40 years of age, IOP above more than 21 mm Hg, glaucomatous visual field defect and optic disc damage, an open angle of normal appearance and absence of secondary cause for glaucomatous optic disc damage. Inclusion criteria: patient of age more than 40 years and older patient lying within the definition of primary open angle glaucoma. Exclusion criteria are patient with hypertension, diabetes, coronary artery disease, tumor, thyroid disease, immune disorder, corneal dilatation disease condition that rise cytokines level like previous ocular surgery, trauma. All subjects will undergo a complete ophthalmic examination, systemic examination and general examination. Results: majority of patients are in between age group 61 to 70 with the mean age of 60.58 year. Distribution according to gender: female are slightly more than male population, and distribution according to best corrected visual acuity. Most of the patients fall in between 6/12 to 6/36. According to right eye, left eye, both are equally affected. The mean CD ratio is 0.69. In terms of treatment outcome, the mean intraocular pressure dropped significantly from 34.60 mmHg pre-operatively to 13.49 mmHg on day 1 and post-operatively continue till 1 month and after on. The number of anti-glaucoma medication also decreased from 3.62 pre-operatively to 1.13 post-operatively, highlighted efficacy of surgical intervention in managing the disease. Discussion: glaucoma is an optic neuropathy in result from acquired loss of retinal ganglion cells and their axon, which are responsible forming the optic nerve. Elevated IOP is the main risk factor for progression of the glaucoma. Other risk factors include advancing age, family history, African ancestry, myopia, perhaps presence of certain systemic disease such as diabetes, hypertension. Conclusion: POAG is predominantly seen in older individuals, with male slightly more affected than male. The significant reduction in intraocular pressure and decreased need of anti-glaucoma medication postoperatively, highlighting success of surgical treatment and controlling the disease. Thank you.
Thank you. The next presenter will be comparative outcome between newer and older surgeries for glaucoma. Shraddha Bharadwaj. No? Shraddha? Anybody जिनका नाम चला गया, कोई आया क्या ऑफिस पहले? Two more presenters only? Two remaining? Yes. Okay. The next will be microsuperphakia in association with anterior segment dysgenesis in Marfanite habitus. Supriya Konde.
Good afternoon, everyone. I'm presenting on a case, microspirophakia in association with anterior segment dysgenesis in Marfanite habitus. Microspirophakia is a rare abnormality of the crystalline lines characterized by the decrease in the equatorial diameter and increase in the lens thickness. It is associated with the various systemic syndromes like Weil-Matthiesseni, Marfan syndrome, Lowen syndrome, homocystinuria, and Alport syndrome, Axenfeld-Rieger syndrome. And locally, it is associated with aniridia, ICE syndrome, and megalocordia. It leads to ocular complications like secondary angle closure glaucoma, subluxation or dislocation of the lens, and intermediate pupillary block and high myopia. Here my case is to report a rare case of a bilateral microspirophakia with anterior segment dysgenesis and systemic association. It is a 36-year-old male patient born to a non-consanguineous marriage presented with a gradual diminution of vision in both eyes since 10 years. On general examination, he has a low set ears, high arched palate, mild dentition, and arm span greater than the height. On ocular examination, AR reading in the both eyes is -20 spherical diopters with -4.5 cylinder in 10 degrees axis, and in the left eye is -20 degrees spherical with -5.75 cylinder, and the axial length is 28.02 and 28.50 mm in the respective eyes. On anterior segment examination, iris is showing iridodonosis and the lens has the phacodonosis. Best corrected visual acuity is counting fingers. On dilated examination, we are able to see the equator of the lens with the zonules. Applanation tonometry readings of 14 mm of HD and 17 mm of HD under no anti-glaucoma medication. On gonioscopy, it shows an opal angle with iris process in all the quadrants. Fundus photographing is showing an high myopic fundus with no treatable peripheral lesion. Chest X-ray showing, to rule out the spine and the chest abnormalities, we have ordered a chest X-ray, but it showed a left-sided diaphragmatic hernia, but the patient is asymptomatic. And serum homocysteine levels are slightly elevated, which are 15.7 micromoles per liter. The result is, this patient is diagnosed as a both eyes anterior segment dysgenesis with microspirophakia, was suspected to have a Marfan syndrome or a homocystinuria. But the genome sequence revealed as positive for Weil-Matthiesseni. Conclusion is, this case shows importance of genetic study in every case. The phenotype of this patient is suggesting of Marfan's and homocystinuria, but the exome sequence came positive for LTBP2 gene, which is in compound heterozygosity variants, which is not present in publicly available population database. This is a rare presentation that the phenotype is suggesting of the Marfan's, but the genetic analysis came positive for Weil-Matthiesseni. So it requires a proper genetic evaluation is required in these rare cases with overlapping syndromes. Majority of the patients need awareness in this of the condition and a regular ophthalmic follow-up. Thank you.
आपकी शुरू की स्लाइड्स लाना एक मिनट. स्टार्टिंग स्लाइड सेकंड थर्ड जरा. क्या हुआ? This slide, like 1 minute. We are presenting from which hospital that is already submitted. Okay. So you need not to highlight that thing more. जैसे किसी ने एक presenter ने बोला कि I am so and so from this hospital. Because 3 minutes, what is important, positive पूरा आना चाहिए. ठीक है ना? Then एक और slide आपकी वो लीजिए जो जिसमें syndromes दिए थे आपने. Syndrome जो दी थी ना correlation में और ऊपर शायद. Syndromes दिए ना सारे इसमें आपने. It is common with. ये जो है तो पूरा आप दे रहे हैं तो हाईलाइटेड इसको थोड़ा सा बोल्ड करके दे दें और जो स्पेसिफिक 4-5 बोल दीजिए, बाकी वी कैन गो थ्रू मीन्स है ना, बिकॉज यू हैव टू कंटेंट इन योर टाइम, और टाइम के बाहर गए तो ऑलरेडी नेगेटिव चला जाता है वो, है ना। तो ये एक प्रेजेंटेशन में हमेशा चीज़ ध्यान रहे कि व्हाट यूज टू बी हाईलाइटेड उसको आप थोड़ा सा एक एक्स्ट्रा उसमें दे दें प्रेजेंटेशन में। दूसरी बात, शॉर्ट टर्म्स यूज़ करते हैं पर ट्राई टू एक्सप्लेन बाय स्पीकिंग फुल वर्ड्स, ओके, क्योंकि दिस हैज़ कम मोर नाउ, POAG ये सब बिल्कुल शॉर्ट में चलता है सारा, और होता है कई बार हम बैठे हमें भी नहीं मालूम थे कुछ शॉर्ट टर्म्स जो में भी है ना, तो प्रेजेंटेशन में इट शुड ऑलवेज बी फुल टोल्ड वंस एट लीस्ट, बाद में आपको जरूर लग रहा है वहाँ शॉर्ट यूज़ कर लें उसको, है ना। ओके, थैंक यू। Next will be last presentation, I think, a case of Golden-Harin syndrome with limbal dermoid by Jyotsna Shri.
Good afternoon, everyone. I'll be presenting a case of golden horse syndrome.
Okay, continue.
A case of golden horse syndrome presenting with limbal dermoid. So a girl, 16-year-old student by profession from Kitcha, Uttarakhand, presented to our OPD with main presenting features of mass in right eye since birth, right-sided facial asymmetry since birth, and right ear deformity since birth. The lesion was progressive, painless, and she complained of foreign body sensation. Prior consents were taken for the disclosure of her identity for academic purpose. Personal history showed she gave no similar complaints in the family, non-vegetarian by diet, no history of any kind of addiction, and normal daily routine. She gave no negative history such as diminution of vision, diplopia, discharge, any kind of trauma, or any kind of ocular surgery in past. Examination was done. General and systemic examination was found to be within normal limits. Laboratory and radiological investigations were found to be within normal limits. B scan was suggestive of query-limbal dermoid with no intraocular extension. Ocular examination showed vision to be 6/6 in both the eyes. Right eye conjunctiva showed an orangish white mass of size approximately 4×4 mm, encroaching 3 mm of cornea temporally with hair on its surface, as we can see in the picture below. Rest anterior segment was within normal limit. Fundus in both eyes was found to be within normal limits. Oral examination was done, which showed grade 1 microtia according to Mark's classification. External auditory canal showed atresia of grade 1 according to VIDA classification. Pure tone audiometry could not be assessed, and low hearing ability was present in the girl since birth. So differential diagnoses were made to be dermoid, granuloma, conjunctival intraepithelial neoplasia, squamous cell carcinoma, teratoma, amyloid, or pinguicula. Final diagnosis was found to be right-eyed limbal dermoid with facial asymmetry, with right-sided microtia with external auditory canal atresia, suggestive of golden horse syndrome. Management was done with right-eye limbal dermoid excision with corneal grafting under local anesthesia, and the mass was sent for histopathological examination. These are some of the post-operative day 1 images of the patient. As we can see, patch corneal grafting was done and sutures were found to be intact. Histopathological examination showed tissue showed to be resembled skin lined by epidermis. Subepidermal tissue was found to be fibrocollagenous tissue with adipocytes. Occasional hair follicles were found. Sebaceous gland, sweat gland, blood vessels, and few nerve bundles were found within, which was suggestive of limbal dermoid complex choriostoma. Post-operative medical management was done with topical and oral antibiotics, steroids, NSAID, supportive treatment. So, to summarize this case, this illustrates a mild penetrance of golden horse syndrome with primarily cosmetic problems. A multidisciplinary assessment of all such patients should be done to identify all the related and more severe anomalies. Prognosis is good in uncomplicated cases with minimal systemic involvement. Thank you.
Thank you. If you noticed some difference in her presentation, Any difference in your presentation and her presentation made? Yeah, no, the way of presenting is different. And she highlighted what is needed to be and very clearly understandable. Very nicely met and nicely presented. And one more remaining will be MIGS in post-TREB, how good in achieving targeted TOP? Vijay Kumar.
So good afternoon, sir.
Yeah, okay.
Thank you, sir. I'm Dr. Vijay Kumar. I'm going to present my study in post-trabeculectomy patients who underwent MIGS. So as we all know, glaucoma is a chronic progressive multifactorial optic neuropathy with intraocular pressure being the only modifiable risk factor. Usual treatment is with medical management with anti-glaucoma medications, then laser trabeculoplasty, and then trabeculectomy. And then in advanced cases, we can do tube surgeries. So with the last decade seeing unprecedented growth with minimally invasive glaucoma surgeries, we have started having good and reproducible results. Though trabeculectomy remains gold standard for treatment in advanced glaucoma, chances of failure is high at 5 years. Up to 40% patients with trabeculectomy have failed. Hence the idea of doing mix in such patients who have failed trabeculectomy in achieving target intraocular pressure. The advantage of mix being faster recovery, topical surgery with minimal or no pain, and no significant vision threatening effects. It's a retrospective study of 39 patients who had failed trabeculectomy surgery enrolled between December 23 to June 24 with the history of primary open angle glaucoma who underwent trabeculectomy with corrected IOP more than target intraocular pressures, who underwent either bent ab interno needle goniectomy, excisional goniotomy with KDB glide, or iStent trabecular bypass system. The patient at least had a 6-month follow-up post minimal invasive glaucoma surgery by the same surgeon. We excluded aggressive glaucomas like pseudoexfoliation, pigment dispersion glaucoma, uveitic and primary angle closure glaucoma, and post-vitrectomized eyes. Pre and post-operative gonioscopy was done in patients, and applanation tonometry at 1 week, 1 month, 3 months, and 6 months have been documented with an anti-segment OCT. We had 21 patients who had success post-mix at 6 months. The patient never needed any intraocular reducing medication, anti-glaucoma medication, with target IOP being achieved. And 16 patients had partial success at 6 months. They need at least one anti-glaucoma medication to have achieved target intraocular pressure. And 2 patients actually failed the procedure, so they needed more than 2 anti-glaucoma medications to have controlled intraocular pressure. These are our results. And with particular procedure, the success rate has been described in this slide. With MIGS bang, 54% had success, 46% had partial success. With MIGS iStent, 50% had success and 50% had partial success. With mix KDB, 55% had success, 36% partial, with 9% failed. Failure was defined as persistent hypotony or IOP more than 21 millimeter or IOP not reduced to 20% of baseline. Traditional alternatives used to be bleb needling, repeated trabeculectomy or tube surgery. With advancement being mix being more affordable than ever before, we tried mix in these patients, and the success rate was IOP drop was 38% with bang and 35% with iStent and KDB with 40%. Mean IOP reduction in all methods are comparable, with bang being the most affordable therapy. Conclusion, MIGS has proven to be a viable option in patients who had failed trabeculectomy. Our study found out that mix done in India with KDB, iStent or bang produced comparable results with Zen implant done in US. Additional prospective studies with larger cohorts are essential to understand long-term efficacy and also late onset complications of mix. The clinical significance of this study is, this is the first case series comparing 3 types of mix and also the first study in India to be done under failed trabeculectomy. Thank you, sir. Yes, sir. Yes, sir. Yes, sir. Long terms, we want. Yes, sir.
Training required for the surgeon, that part is also very care.
Yes, sir. Yes, sir. Thank you. Thanks.
So to conclude, thank you very much to all the presenters. You have all done good job. But presentation is one art. That how you present means long-term speaking for the topic. जैसे बहुत सी स्लाइड्स बड़े-बड़े कंटेंट लेके आती है, तो उसमें क्या-क्या बोलना, क्या छोड़ना, that is important. So try to be specific 10 lines maximum आपका जो 18 या 21 साइज पे आप चलते हैं. Secondly, जो आपको आउट करना है, आपने लिखा है उसको पूरा बोलना जरूरी नहीं है. You can, because time constraints is there always. अभी तो आपको टाइमर दिख नहीं रहा, टाइमर दिखता है आपको सामने कई बार on the screen ना. So that is the second thing. Because in time is the one thing which is taken care. And content को कैसे इसको हाईलाइट करना, इसको छोड़ना, it is very important. So out of all जो भी I can decide, I will give the results. अभी डिक्लेयर करना है. रिजल्ट कब देना? वो देना बाद में.